This is Norwich Confidential with your hosts, Dr. Ben Hong, Bonnie Hong, and Mr. Bob Farwell.
Good evening, and here we're again live in Norwich.
Good evening.
I'm Ben Hong.
And I'm Bonnie Hong. We have a very special guest with us this evening, and
That's
a
right.
topic that is close to both of us. I think the first time we really began speaking about single-payer health care was during Congressman Courtney's very first term. That had to have been when 2008?
Yes, it's about 8 years ago or something like that.
Or a little bit more than.
But actually, we did mention about that, and we did have a program when this whole thing came out years ago,
Right.
and we did make a presentation on the single-payer plan.
And then when Courtney was running, we tried very hard to get him to sign on to H.R. 676. But
And unfortunately, that did not happen. So in any case, we have Dr. Zarr tonight, and he is live from Washington, D.C., and he is the president of the PNHP, or the Physicians for a National Health Program. Is that correct?
That's right.
And we really are very, very fortunate and honored to have him be with us tonight, because if there is a person who's more knowledgeable about this
Single-payer?
type of program, that doesn't exist, and that
Right.
he's the ultimate person that can answer to you all the history as to what the national and single-payer plan is going to be, or at least what we plan on
But we're still advocating for.
advocating. That's
Yeah.
correct. So why
I'd
don't
like
you do
to-
your own
I'll just
introduction,
give
Bonnie?
just a bit of a short, brief introduction to Dr. Zarr. He received his medical degree from Baylor College of Medicine and completed his pediatric residency at the Texas Children's Hospital in Houston. His current practice is in Washington, D.C., where he cares for low income and the immigrant population. He also received a master's degree in public health, specializing in international health from the University of Texas of Public Health. It really is our pleasure to introduce Dr. Zarr, who is the president of the Physicians for a National Health Program. Good evening, Dr. Zarr.
Good evening, Dr. Zarr.
Good evening. Thank you for having me on your show tonight.
Well, we have a lot of questions to ask you, but first, would you tell us exactly what position you are and what your organization is trying to do?
What is
Sure,
the-
I'd be glad to. So right now I currently serve in a volunteer capacity as the president of Physicians for a National Health Program. And when I say voluntarily, it means that I have a day job practicing primary care in Washington, D.C., and that's my day job. My evening and weekends and time in between, I advocate along with 19,000 other physicians and medical students around the country for improvement and expansion of Medicare, so that we can have finally a fair and just and cost-effective way of providing health care to every American.
You know, there's a lot of probably, I would say, either not understanding the program, or misunderstanding it, or misinterpreting it, or sometimes intentionally using a kind of a difficult to understand words. So we have your organization as the Physicians for a National Health Program, or otherwise called Expanded Medicare for All program. Is that correct?
Yeah, I think that that's very, very accurate way to describe it. And it's interesting because I think that the opponents of single-payer national health insurance through improvement and expansion of Medicare would like to make it look as if it's complicated. But the reality is it's simple and it's quite elegant, and it is ultimately the only way in which we are going to have universal coverage, and that means every American with a comprehensive package of services that are necessary. So that would include things like primary care and specialty care, long-term care, and it would be done in a way in which we would use a progressive taxes so that everybody would contribute to this, and it's really the only fair way to do this. So if you have a high income or a higher income, you would contribute more through taxes. And if you had a very low income or you were unemployed, you would contribute less to this National Health Fund, which is where the money would be kept in order to pay the provision of services. That is, pay your doctor, your pharmacy, medical supply companies, dialysis centers for the care that you need.
Yeah, but before we get into your specific plan and program, again, let's try to differentiate some of these terms just to classify and clarify what you're saying. Now, there's another term that often is confused with your single-payer plan, and that is called the Universal Health Plan. There are times during the elections when, as a matter of fact, politicians really cannot differentiate between single-payer and the Universal Health Plan. So could you define to us what Universal Health Plan is that everybody seems to be using to define coverage?
Well, being universal is just that. I think people make it more complicated often than it really is. I mean, universal means that every single American, or every single resident, to be clear, living in the United States would be eligible and enrolled in this national health program. And there shouldn't be any confusion about the word universal. Single payer is not just universal, meaning that it's not just every American, but once again, it means that every American would be enrolled to have a comprehensive package of benefits from the day you're born to the day you die. And there would be no deductibles, there would be no co-pays, and very little cost sharing except the taxes which you pay every year that goes into this National Health Insurance Fund.
Much like the way we pay for Medicare today.
Exactly.
Yeah.
So Medicare is an example of single payer that refers to Americans 65 and older. So one of the things that I am oft saying is that single payer national health insurance would be Medicare, but you take out those three words, under age 65.
Right.
So if you took out those three words, then you would have what I'm talking about, which is essentially a single payer system.
Well, I'm going to get back to that to ask you another question later on, but we're still in the definition stage. So another term that I'd like you to define, if you could, is the Affordable Care Act, or what we now know as Obamacare. Could you give us a definition as to what that covers and how is it different from what we're proposing to talk about?
Sure,
today?
that's a great question to ask. So, the Affordable Care Act that was passed in 2010 is, in fact, in stark contrast to taking Medicare, a program like Medicare, and expanding it to every American. And when I say in stark contrast, what I mean by that is that the Affordable Care Act is still relying on private health insurance companies. And private health insurance companies is the basis of the Affordable Care Act. And private insurance health companies are inefficient, they're wasteful. And when I say wasteful, we're talking about an average overhead of about 12%. But some companies, like one of the largest companies, insurance companies like United, has an overhead of 18%. So very, very inefficient and very profit-driven, especially for their shareholders and their stockholders. In contrast, Medicare, it has an overhead of about 2.1%, and even in its current state, meaning it's very privatized now. We have these Medicare Advantage plans, and we have an element of profit that's being made within Medicare. But even within this current Medicare, which is not what I'm promoting, and 19 other physicians across the country who are members of Physicians for a National Health Program, which is we're promoting, we're advocating an improved and expanded Medicare, which would also eliminate these Medicare Advantage plans. So we wouldn't have those options anymore. And, it would create a situation in which, the only thing you wouldn't see anymore as a patient is the bill, right? So everything would be taken care of in terms of the cost. And that, once again, would be provided largely by a progressive tax.
So actually, you answered my question that I was going to ask. So, Bonnie, do you have anything to ask?
Yes, I've got a couple of questions because when you're talking about expanded Medicare, we have to remember and let the audience remember that currently Medicare does not cover things like dental, like eye care. I mean, there's a lot that Medicare does not cover for the elderly. So when we talk about the single payer, you're talking about expanding it for all of these services that are currently not covered.
That's exactly right. And so that's why, the current bill in Congress that best represents single payer national health insurance would be H.R. 676. And this is a bill that is authored by Conyers, Congressman Conyers from the state of Michigan. And yes, it is a very comprehensive basket of coverage, which would include dental, all specialty services, vision, mental health, rehabilitative, habilitative. So it's a very long, extensive list. There's a few things, for example, that it wouldn't cover. It wouldn't cover like cosmetic surgery. It would cover plastic surgery, especially in cases of reconstructive surgery. So, it's not every possible medical need that one can ever imagine, but it is the most comprehensive package of benefits compared to anything anybody has currently with private insurance.
One of the things, we were at the community clinic. United Community and Family Services is a very large community clinic in Norwich. We were there at noontime today with our Rotary Club. One of the topics of discussion actually was the amount of work our United Community and Family Services did in registering people for the Affordable Care Act. And there were thousands and thousands and thousands that they were able to register. However, one of the statistics that they told me was that you had closer to 40% of all those that came in that really were more qualified for Medicaid than for one of the programs in the Affordable Care Act. So they were able to register them for our Medicaid program. But then when they began talking about how poorly they were really served by the Affordable Care Act, what the deductibles were, what they have to meet before the insurance even begins to pay. Could you address that issue a bit?
Sure. So, I think in its very, sort of fundamental flaw, the ACA, as I said earlier, relies on the for-profit, inefficient private health insurance companies. But when you dig deeper, you find out a little bit more. And and you just mentioned it yourself, which is that a big part of the Affordable Care Act is expansion of Medicaid. Now, that's generally, a good thing for people who are living, near or in poverty to be able to qualify for Medicaid. It allows them to have access to the provision of medical services that they would otherwise not have. But there was another Supreme Court decision, if you remember, where the Supreme Court allowed states to make that decision on a state level whether they were to expand or not expand Medicaid. And so, despite ACA passing, we have a situation now where we have more than 20 states whose governors have either chosen not to expand Medicaid or have been politically unable to do that in their states. And this has left millions of Americans still without access to basic medical services. Now, your other point about the complexity of signing up on the exchanges is also a very salient one, and that is that we have these tiered systems, tiered choices in ACA, Affordable Care Act, and they range quite a bit in their deductibles and copays and benefit package. And in addition to that, we are right now in the middle of another Supreme Court decision that will make a very, very important change if the Supreme Court favors on the side of King. This is a case called King versus Burwell. And if this Supreme Court favors on the side of King, what it'll essentially do is not allow people living in those states without state exchanges set up to use federal subsidies to purchase health insurance on the federal exchange. And so that would leave out yet another 9 million Americans who would otherwise be covered under Affordable Care Act. So I bring this up because it highlights and underscores, frankly, the vulnerability of the Affordable Care Act and the need for us to have a national health program where everybody is included, and the simplicity of the system would allow enormous savings in administrative waste in upwards of $400 billion a year.
Yes.
Go ahead, Ben.
So we're going to have a little bit of station break, and again, this is Norwich Confidential, and I'm Ben Hong, and this is Bonnie. And tonight we have a guest from Washington, D.C., and he's live on our, was it a Skype, Bonnie?
We're on Skype.
And his name is Dr. Robert Zarr, and he is the president of the Physicians for National Health Program, otherwise maybe synonymous with the single-payer system. And he is going to talk to us about what this program is all about and why it is the endorsement of 19,000 physicians and medical school students all over the country. And for the simple reason that, like everyone said before us, that our health system, meaning the management of healthcare, seems to be not running very well, that there are so many challenges, that so many roadblocks. And what we really envision is a system or a plan that is very comprehensive and that it will last lifelong for as far as the patient is concerned or the person, and that it should be affordable and it should not bankrupt the entire country. So there should be cost control as well. And Dr. Zarr has been kind enough to give us some idea as to what he had been doing. So I'm going to give you back Dr. Zarr, and he'll explain to you what his organization is trying to do, not just to educate the public, but also to educate our lawmakers, and hopefully we will educate some of our pharmacists, pharmaceutical companies, as well as insurance companies.
Dr. Zarr, it's not just the Physicians for a National Health Program and the American Medical Student Association, the California Nurse Association. There were unions, labor unions, that have endorsed H.R. 676, single-payer health care. I mean, the list was very impressive. You're one of many groups that are working together.
Yes, that's correct. And having said that, it is now we're at a point in history in American history, where not only do we have 19,000 members, which is a phenomenal growth in our membership since 1986, but really more importantly, when we've polled physicians across the country, over 13 specialties across the country, on two different occasions in 2002 and 2007, what we found out from asking a very simple question, which is, as a physician, do you support the establishment of national health insurance? And the answer is yes, for the vast majority of American physicians. So we are no longer living in a country where physicians are unclear or undecided about their feelings toward establishing national health insurance. So we have a majority of the physicians who support establishing national health insurance. We also have a majority of the public who's been polled many times and asked a very similar question if they support expanding and improving Medicare for all. And the answer is yes. As you mentioned, we have hundreds and hundreds of labor organizations, chapters in the AFL-CIO, who have endorsed HR 676, our bill for single-payer national health insurance. We have certainly nurses on board with this as well, with National Nurses United and the California Nurse Association, Healthcare Now, Public Citizen, American Public Health Association. So we have a very long list, as you said, of support for this around the country. So there's no shortage of people who not only understand what's at stake here, but who are willing to state their opinion strongly that it is ready time for us to have a sane, logical way of financing healthcare in this country so everybody can have an equal opportunity to be healthy.
Okay. Did you?
Oh, yes. We'll give you some time to really explain in details if we have time.
But one of the things I'd like to have him address immediately, though, I'm sure you've heard it, and as whenever both Ben and I have talked about single payer to any large group, we always have 2 or 3 people that immediately say, this is socialism, and we don't want socialism. Would you like to begin addressing the number one, or it's always the first statement that's said in a group?
Well, I would say first off that single payer national health insurance is a very middle of the road plan here. I mean, we're not talking about government takeover in any definition of the word. What we're really talking about is keeping the delivery of healthcare. That is, the doctors and the hospitals and pharmacists, people who supply medical technologies, etc. Keeping that in the hands of those who are currently delivering the care, which is primarily still a very private world. So the delivery of care would really remain largely in the hands of those who are doing that. The difference would be that rather than having a for-profit delivery system in many instances, that aspect of it would become a nonprofit. So we firmly believe that that there really is no role for profiteering in the delivery of healthcare, or there shouldn't be in our country, or for that matter anywhere in the world. So it's a far cry from socialism, where the government literally owns and runs the hospitals. So we're not talking about a situation like that at all. What we're talking about is a fair way of financing delivery and making sure that, as Ben had pointed out, that nobody goes bankrupt in the process, and that physicians and other clinicians around our country can actually practice medicine. I mean, I find it increasingly difficult to do the simplest of tasks, prescribe a medicine for an ear infection, when the formulary of the private insurance company changes so frequently. It's hard to keep up with. So, you can imagine so many levels, the simplicity of a system where we, for example, would have a national formulary, and we would have all the medicines that we consider essential for all Americans. And there would be so much ease and decrease in frustration, both in patients and in their physicians, just to be able to practice medicine without having to worry if your patient can afford the treatment you're recommending.
So you're practically proposing, your group is proposing a system wherein everybody is covered, and that it should be at least a not-for-profit system. Basically, hospitals, pharmaceuticals, is that correct, and physicians, other forms of ancillary health care. Primarily what you're trying to do is to get the profit out of medical care.
Out of the insurance.
Yeah.
Out
Okay.
of the insurance.
With a single-payer national health insurance, there would exist no longer private health insurance. There's no need to have a duplication of services.
And yes.
Especially when the private insurance companies are very inefficient and spend in upwards of 1/3 of their budget on marketing. So there really is no role anymore for private health insurance, except in circumstances where, let's say, you needed to have insurance for cosmetic surgery, for example. So there would be some instances, but by and large, there really is no more role for private health insurance. What we would require is that if you're delivering health services, you're an actual physician, that you would either be in solo practice or group practice or work for even a larger system, but that system itself would be nonprofit.
And primarily that also includes the cost of medications, is that correct?
So yes, so in the bill that best represents improved and expanded Medicare for all, HR 676, all necessary medicines would be covered under this plan.
Now, one of the criticism for this type of plan is they will look at Canada or the UK and say, well, I waited for a year just to get my hip replaced, or that there's a long queue for doing a simple procedure, whereas in the United States, you can get it tomorrow if you wanted to. And that is one of the biggest criticism that we find whenever we have, say, a public hearing. And what system would you like?
Well, that's a good question, a good comment. There's about an average of about 10 common myths that the opponents of national health insurance, single payer, like to confuse Americans with, and one of them is this myth about weights in Canada. And yes, it is true for particular elective surgeries like knee replacements, hip replacements, cataract surgery. There can be a wait list, but if you compare the wait for an uninsured American to that of an insured Canadian, then come back to me and tell me that Americans are faring better. So we know that still today we have over 40 million Americans who don't have health insurance, and by the end of full implementation of ACA, there will be in upwards of 30 million Americans still uninsured. And if you remember back in 2008, 2009, there was lots of talk about universal health care, and leaving out 30 million Americans is a far cry from being universal. So I think you really have to compare apples to apples and oranges to oranges when we look at Canada to the U.S.
I think
and you'd be hard-pressed to find a Canadian who would praise the American healthcare system.
Your point of the wait times compared to somebody that has insurance and someone that does not, Dr. Hong had been in primary care, adult internal medicine for 35 years in this community, and trying to get a specialist to see one of our patients, they would have to go from Norwich to New Haven, the wait time, or to Farmington, Connecticut. The wait time for someone with insurance, when I was referred, I had an appointment the next week. I did that as a test because we had been trying for 3 months to get an appointment for one of our patients, and their appointment time was 6 months down the road. They had Medicaid.
That's
So
right.
even if they are insured, and certainly Medicaid is an insurance, they still are put at such the low end that they never get seen. But one of my pet peeves is when people say, I want to keep my private insurance, and they're working for a U.S. government contractor. When every penny of their salary and their health care is paid for with my tax dollars, they want to consider that private insurance, and in statistics, it looks like it is part of the private insurance plans. However, we already know that you have about 60% without the contractors of health care that is already paid for by our tax dollars.
That's right.
So when you then add in local, federal, state government employees, you then add in all of the contractors, the military contractors in particular, who do not manufacture any private goods that you and I could buy, but their entire salary and their entire private health care is paid for with our tax dollars. I don't think that is part of the money that you are considering that is being saved with a universal health care.
Well, let me just take a moment to comment on the things you said about this person who doesn't want to give up their private health insurance. I would make an educated guess that this person probably doesn't know about the benefits, the enormous benefits in having single-payer national health insurance. And I would venture to say that if this person you're talking to, if you explain to them that they would have no more cost sharing, no more deductibles, that is, no more co-pays, and they could see any doctor, go to any pharmacy, go to any hospital, anywhere in the country, in other words, have complete freedom of choice to go wherever they want, and have all of that paid for through taxes, I think if they knew that, and it was explained to them in that way, and that they would never again receive a bill, and they would never again receive another piece of paper from an insurance company, I would venture to guess that they would be very much in favor of that. So I think that we have a segment of our population still who hasn't really had a chance to learn about what single payer really means. And I hope that a program like yours and this conversation can help along that path in educating everybody what exactly it is we are advocating for.
Because one of the things that most people don't understand until they're put into a situation where they have to have approval, not by their physician, not by any medical staff, but by their insurance company. It is the private insurance in this country that actually controls their health care. They decide what medications they can have. They decide what surgeries they can have. There is currently on, I believe it's change.org, has a petition for a 37-year-old young teacher in New Jersey who has been fighting his health care just to get, what is the surgery again? You had a patient whose daughter wanted the same thing. It's the heated chemotherapy. And it's been denied, and it continues to be denied in spite of the fact that it is not experimental. It's the only one that's being advocated by his physicians. And the horror stories when you know of other people that have had it denied and continued to fight to try to get it, and it's finally approved 4 years down the line. when that person is now under hospice. You know, I mean, that's control of your health by.
Well, yeah, and imagine that's true. And imagine, these decisions are made, behind closed doors in boardrooms of these insurance companies, and the decisions are made to deny care so that they can make as much profit as possible. So, the purpose of a private for-profit insurance company is just that. It's to make profit. And I think once you understand that that's the purpose for the existence of a private insurance company, well, you have no choice but to come to the same conclusion that I have, is that we don't need them. We don't want them. They are not they don't provide any value to our society. And in order to democratize our health care, they cannot have a role. The private insurance companies may not have a role in our country. They can exist, as I said earlier, for providing insurance for what's not covered. And for example, as I said earlier, there's few services that won't be covered, but most things will be covered. Most things that are considered necessary will be covered. And the kinds of decisions will be made, fortunately, in public debate. And we need to have those. And so, going back to your previous comment about the waits in Canada, we actually don't have accurate data in this country as to waits in the U.S., primarily because it's not in the public domain. So we are not privy to that. You have, politicians running campaigns in other countries around the world, in civilized countries around the world, talking about how they're going to reduce the wait time to see an orthopedic surgeon for a knee replacement. We don't even have those discussions because they're not in the public domain. They're still behind closed doors, where boards of directors are meeting and having these secret discussions about how they're going to make more profit and how their CEO is going to make millions of dollars.
I mean, a $40 million salary is
necessary medical care.
Yeah, a $40 million salary for the heads of these insurance companies, and those are generally without their additional benefits. It's almost obscene, but.
Yeah, we'll take a station break again. We have Dr. Robert Zarr. He is the president of the Physicians for a National Health Program, otherwise known as Expanded and Improved Medicare for All. And if you're all familiar with how Medicare works, just imagine if our system will be like Medicare, but it will cover everyone that is here in the United States. And the purpose of this program is, of course, to see if we can deliver care in a better and efficient way, and that the access will be universal to all, meaning that everyone should be able to access medical care and be able to see their own physician, and also have an affordable as well as a controlled financial cost for their health care, rather than give it to profit and insurance company. So if you have any questions, of course, please give us a call. This is live, and I'm going to give you back Dr. Robert Zarr again, and he is going to explain to us how this single payer system can be funded. Dr. Zarr?
Sure. Thank you again for having me on the show. The funding mechanism will be primarily through a progressive tax. So, as I said earlier, this is not complicated. Every other industrialized country in the world does this. And, there's an Organization for Economic Cooperation and Development, the OECD, which includes the U.S. and 29 other of the richest countries in the world. And all of them except us do just that. They have a progressive tax that provides, not necessarily single payer in every one of those countries, but every citizen of those countries has government assured insurance and access to health care. And they do it at a fraction of the cost. We by far spend more per capita. We're right now spending over $9,000 per capita on health expenditures in this country. And that's usually more than twice the amount that's spent in any other country in this world, with the exception of Switzerland. And even though we do spend more per capita than Switzerland, by the way. And as Bonnie pointed out earlier, if you look at the just public spending alone in this country in terms of healthcare expenditures, we spend more in public expenditures already than the total health expenditures of any other country practically in this world except for Switzerland.
But the outcomes,
I'm often saying that we already pay for healthcare. We just don't get it. And we don't get it because of the $400 billion in waste that is driven by this for-profit insurance industry.
Do you have the statistics on the outcomes? For example, where the U.S. stands on
infant mortality.
Infant mortality.
Sure. Yeah, sure. So I can tell you that we are not the lowest in the world on infant mortality. We're not the lowest in the world for maternal mortality. We certainly do not have the highest number of MRIs and CT scanners per capita. We don't keep you in the hospital for more days than other countries, meaning it's a measure of how civilized a country can be in terms of how quickly they kick you out or keep you in after having had a serious surgery or giving birth to a child. So in many, many measures, metrics across the world, we fare quite terribly. And the World Health Organization puts out a report card comparing the U.S. to all the other countries, and we fall around 37 in our ranking of all the countries in the world.
That would surprise many people because they keep wanting to say we have the best medical care, and they're right if we can afford it. However, for those that can't, that's really why we're ranked 37th in the world in quality health care. But
I would like to point out that that certainly the very, very most important first step in reforming our healthcare system would be through finance. We need to finance our healthcare through single-payer national health insurance. But there's a lot of work to be done beyond that, Bonnie. Clearly we have a grave shortage of primary care physicians and clinicians in this country. And I've seen estimates as high as 50,000 right now. We are lacking. That's the deficit of primary care physicians and clinicians in this country. So we really have to take seriously the ratio or the misratio between specialists and primary care, just to give you one example. And of course, quality improvement is a lifelong task. And there are many things that we can do, within our hospitals and practices where we can deliver better care. And that's been shown, in systems like the VA. It's been shown in other countries, in systems like Kaiser. So we have some systems that have shown us good examples of how we can improve the quality of care. But as I said, the very most important first step would be to fix this financing nightmare right now, where we spend more than any other country per capita and do not have the best health outcomes.
One of the, is it okay if I ask?
Sure,
you
go ahead.
Okay. In HR 676, it does not address the funding, but I know that the advocates for funding have actually laid out how it could be funded in a very simple, easy, unpainful way for all Americans. Because actually by just increasing the payroll tax, For an employee, it would be 3.3%, and for the employer, it would be 4.5%. In addition, they want to establish a 5% health tax on the top 5% of income earners, which would be somewhere over, 300,000, I think is about that, and a 10% tax on the top 1% of wage earners, 1/3 of 1% for stock transaction tax, which would, again, close some of that, when that corporate tax, stock tax was cut, it affected our entire federal budget, so I thought that was interesting. But you would not have a dramatic increase in what we're paying in taxes. It would simply be coming out of our payroll taxes currently, but we would not have our deductible for what we're paying as a working person, that the employer's taking out to buy our health care as an employee. So a lot of times it would be even less than, it seemed to me, it would be less than what they're currently paying now.
Yeah, so just to back up a little bit, the Congressional Budget Office has never to date, not yet done to date, a sort of financial analysis of HR 676. So that is something that we do need to have done. Having said that, I like to explain it, even simpler to most people, which is that, most Americans, the vast majority of Americans, would see a decrease in the amount of money that they spend on health care. That is really indisputable. So that's a fact. But if you think about taking the money that we're currently spending to support Medicare, Medicaid, the VA, all of the federal subsidies that goes to employers to provide health insurance, you save an enormous amount of money if you take all of these separate bureaucracies and you have one payment system for everyone. So and that's just the first piece of it. The second really big piece of it is that you save millions and millions of dollars by bulk purchasing. And so what I mean by that is if you have expanded Medicare for all, then the government, on behalf of its people, can bring down the price of medicines and health technologies because it's bargaining on behalf of 300 million Americans. So when the U.S. government then goes to the pharmaceutical company and says, I would like to purchase, this many pills for 300 million Americans, the price comes down. So bulk purchasing is an enormously powerful way to reduce cost. And you can't do that with all these individual systems.
Well, that is true, because right now, as a matter of fact, what you just said is true, that there are duplications and all coming from the government expenses. For example, a VA patient can go to a VA hospital and get treated at the expense of the VA budget, but at the same time, he has Medicare coverage. And that Medicare coverage is also paying for some of his health care, either outside of the VA. So there is duplication of the coverage, and that is a very inefficient way of running or caring for a patient financially.
That's right, and we see that in the privatization of Medicaid and Medicare as really obvious examples of why privatization is bad for our country and bad economically and financially. When you take taxpayer money and you hand it over to for-profit insurance companies to run these managed care organizations for Medicaid and Medicare, what you do is you introduce tons and tons of waste, millions wasted every year, and you don't get better outcomes. And therein lies a huge irony and travesty for our country, is that we take taxpayer money, we give it to insurance companies to quote manage care, and we don't see better health outcomes, and we see higher overhead. We see these companies are inefficient at running. So it's far overdue that we get rid of all this duplication of bureaucracy. And you see this once again with ACA or the Affordable Care Act. You see creation of more bureaucracy to create these exchanges to sell Americans private health insurance that is largely funded by taxpayer money again. So it really makes no sense how complicated it has become for Americans to understand, and it really is what makes me so passionate about the logical, rational way, based on many, many years of evidence, to establish single-payer national health insurance.
Okay. Well, Dr. Zarr, let me also present to you my own personal observation, and that is that what you are proposing and what your organization is doing is really very good, except that there's, of course, a lot of physician involvement in that. As a matter of fact, the first article that came out in the New England Journal of Medicine is was written by a physician for a Medicare for All concept. Now, what I'm observing is that in our present system, we really have very few physician involvement in policy making, in politics regarding medical care. We have Medicare audits that is being done by nurses, and some of the staff that were hired by private corporations don't even have any medical background, and they're asked to audit medical necessity based on what they can read in the chart, and then make a denial decision out of those. So we really have very few physician involvement at this present system. Now, what you are proposing will involve a lot of physician input into it, either by administering the system or the program, implementing the program, policing the program, or even doing oversight. So how is that going to affect the physician group if we're asking them to do it?
I would actually suggest that in our current irrational system now, we see thousands and thousands of nurses and medical doctors working for health insurance companies across the country, and those individuals are often the ones with whom we have to talk as practicing physicians, that is, to try to override a denial of a service that we think is essential for our patients. So I would actually posit that with single payer, we could see literally thousands of nurses and doctors given an opportunity to return to actually practicing medicine. What I see happening right now is very concerning to me in the field of medicine, which is burnout and frustration and sometimes even depression among clinicians because of the administrative burden placed on them to get through the day. So with the advent of electronic health records, which is largely linked to billing, the purposes of electronic health records has been largely driven by the industry to increase the likelihood of getting paid for the services you provide as a physician in this case. The problem with that is that they're often not very physician friendly. And so we find ourselves, checking boxes all day, and oftentimes having to document in the chart the same information several times, which is really unnecessary. And so I would suggest quite the opposite, that when we have, because we will have national health insurance, it's a matter of time, when we have it, we will see a very dramatic change in the attitudes in physicians, and frankly, I would suggest and predict that in a system like national health insurance, where we have single payer national health insurance, that physicians will be more likely to keep practicing and for longer when you reduce this administrative burden on them. So I would actually say quite the opposite, that you will see sort of a removal of this weight on our shoulders every day, just trying to get to the day the best we can, but being overburdened with lots of paperwork.
We only have about 5 minutes left, Dr. Zarr. If I could ask one last question. With King versus Burwell,
Burwell.
within the Supreme Court. Now, if that actually decides that the 34 states that do not have not set up their own exchange, and 9 million people lose their health insurance, do you think that might be the trigger that starts this a real uproar for single payer?
Well, I want to say first of all that I do not wish on any American to lose their health insurance.
Right.
I'm at the end of the day and the beginning of the day, I'm a pragmatist. I mean, I go to work and I, provide primary care to my, over 1,000 patients. So I don't want anybody to lose their health insurance. Having said that, if 9 million Americans lose these federal subsidies to purchase their health care on the federal exchanges, they will be unable to afford health care because they will be unable to afford health insurance. And if that happens, it further weakens the affordability of the Affordable Care Act in terms of the health insurance one can buy. It's affordable for them. But it also will weaken the benefit packages and the comprehensive the packages that their plans would provide them. So, it would be a huge hit to the Affordable Care Act, and regardless of whether the Supreme Court favors in favor or against King, we still need to have a strong movement to single-payer national health insurance, because even if those 9 million don't lose their federal subsidies and the Supreme Court does not favor on the side of King, we still have a horrible system for millions and millions of Americans and for hundreds of thousands of physicians.
We're going to be cut off.
That continues to put profit in the hands of a very, very small group of individuals.
Right. We're running out of time, Dr. Zarr, but I do have a few questions, which I think we can bring you back.
We're going to have to bring you back, Dr. Zarr.
We have to bring you back. So that's it for tonight, folks.
Thank you very, very much, Dr. Zarr.
This is Norwich Confidential.
And we will see you next week.
We will see you next week.
Thank you so much.
Thank you.
Thank you for having me on your program tonight.
It was a pleasure.
Take care.
Okay. This is Norwich Confidential with your hosts, Dr. Ben Hong, Bonnie Hong, and Mr. Bob Farwell.